She also serves as a Climate Health Research Fellow at the Health and Human Services Office of Climate Change and Health Equity. Her interests lie in the nexus of climate change and healthcare, with a focus on raising awareness of its impacts on cancer patients and advocating for healthcare decarbonization. She's a founder of UCSF's Green Health Lab, a research group of over 20 members engaged in various healthcare climate projects, including life cycle assessments, waste audits, and studying climate-related effects on national cancer outcomes. Thank you so much for being here with us today, Katie, and we're excited to hear you speak.
Great, thank you, and good afternoon, everyone. And thank you to UCSF Graduate Medical Education for organizing this webinar. It's a true honor to have the opportunity to talk about this topic of decarbonizing our healthcare system. And this afternoon, I'm going to speak from an oncologic lens and my experience navigating this as a resident in radiation oncology. But I hope to keep takeaways pertinent for all healthcare providers, regardless of specialty. I have no financial disclosures to report. And so this afternoon, I want to start us off by talking about my journey into climate and health space. So being from Minnesota, the appreciation and the advocacy for protection of our land and our communities that inhabit these spaces was woven into my upbringing, spending summers canoeing the many 10,000 lakes that we are known for. But it was in my intern year that I saw the link to health. It was an overnight shift that I was working in the COVID ICU units when a gentleman was admitted with progressively worsening lung cancer. Due to the wildfires in Northern California, he had been displaced from his home and he had missed several weeks of essential chemoradiation. As I walked home, the skies were dark. It was the day of the orange skies in California. And I began to realize that this story of the one gentleman was not unique to just that single patient, but that patients throughout my career were going to be affected by climate change, whether it be wildfires or a global pandemic. And that simultaneously, as I took off my PPE and grabbed my reusable grocery store bag, I felt a call to action to go beyond just using a reusable grocery store bag at home and start to question how the medical field is contributing to climate change. And so I ultimately sought out to answer these three questions. How does climate change impact cancer care? How does cancer care or the healthcare sector impact climate change? And how can we organize to inspire the change that I want to see? So today we know that the climate crisis is recognized by the medical community as an urgent and growing threat to the health of patients' well-being, with a momentous event that took place in 2021 when over 200 medical journals simultaneously published a call for emergency action within the healthcare field. This had never been done except for with COVID. And today, the impacts on health and outcomes are numerous and wide-reaching as rising temperatures and changing weather patterns associated with climate change fuel extreme weather events, many of which we here at UCSF have experienced even over the last 12 months, including heat waves, droughts, wildfires. And such events not only threaten our ecologic community, but also the health of our patients and our populations through a variety of pathways. Just to name a few, some of those include extreme heat and air pollution, leading to exacerbation of cardiovascular disease and asthma, changes in vector ecology, worsening malaria, dengue, zoonotic diseases, and environmental degradation leading to forced migration and conflict. And overarching all of this, and what certainly cannot be understated, is the mental health implications on all patient populations. And these impacts are far-reaching across all medical specialties. But I found it helpful to start in my own specialty where I felt like I had a sphere of influence. And so just looking at oncology, we unfortunately know that it's not immune to climate change, with known impacts all across the cancer care continuum. And this includes increased risk of cancer from increased exposures, including air pollution, chemical toxicants, and even infectious etiologies of cancer. But also that climate change-related disasters disrupt essential health systems and behaviors needed for detection, diagnosis, treatment, and even follow-up care. And we saw that not only in times of COVID, with patients missing preventative screenings, but also extreme weather events when patients, treatments, and follow-up appointments can be disrupted. And so going one level deeper, and what I would argue is key to building both awareness and getting information for future climate action plans, is to first understand the impacts on specific regions and how it impacts our patients. So just looking at California, our team found that out of the 176 radiation oncology clinics across California, all 176 clinics were within 25 miles of a wildfire within the last 5 years. So certainly a radius capturing many patients' homes and communities. And when we surveyed these clinics, 60% of the physicians reported direct impacts on their clinics and staff, with common impacts being clinic closures, home and clinic evacuations, financial burdens, staffing shortages, and power outages, just to name a few. And we know that such events impact patients' survival. So our team at UCSF looked at wildfires, and we used national FEMA data and then NCDB data as well, a national cancer registry. And we looked at wildfires' impact on lung cancer patients who were undergoing radiation. And we found that not only do patients have longer treatment times, but they also had worse 5-year survival. And additionally, we know that climate change further magnifies healthcare disparities, as the effects have disproportionate impacts on the most vulnerable patient populations. And so how can we begin to think about which patients are at increased risk or particularly vulnerable to climate change? I found this framework to be useful. So there are 3 factors that influence or that determine vulnerability to climate hazards. That's exposure, sensitivity, and adaptive capacity. So exposure, we're thinking about human contact with environmental hazards, sensitivity being the degree to which climate hazards impact humans, and then adaptive capacity, an individual or a community's ability to cope with climate hazards. And so when we're looking at a subset of patients, such as cancer patients, we can begin to understand how they are particularly vulnerable to the health hazards of climate change. So with cancer patients, they have unique physical, psychological, and socioeconomic consequences of both their cancer diagnosis and its treatments. And so I will walk us through understanding how cancer patients may have increased sensitivity to health hazards of climate change. So for example, some cancer treatment drugs can inhibit thermoregulation, leading to vulnerability of heat waves. Additionally, patients may have impaired organ function that may similarly alter their ability to respond to heat waves or poor air quality. They may have a weakened immune system that makes individuals more vulnerable to infections, which can be common during events such as flooding. And then certainly there are cognitive and psychological impacts that also increase sensitivities. But also cancer diagnoses and their treatments have socioeconomic consequences that may reduce a patient's adaptive capacity. For example, there are numerous expenses that arise during both cancer treatment and survivorship, and patients' ability to remain employed may be altered, which can ultimately impact their adaptive capacity. Patients may have reduced ability to evacuate, to seek daily transportation required for their therapies, or to adapt their housing infrastructure to cope with extreme weather events or poor air quality, such as improving insulation, installing AC units, or specialty air filters during wildfires. And so this picture shows a spike of EMS calls and notes an increase in ED visits during the heat wave of 2017. And it's reasonable to think that this would include our vulnerable cancer patients who are undergoing active treatments and lack the adaptive capacity to respond to such events. And we know that people are more than their cancer diagnoses. Due to how society is structured, different individual characteristics, including the groups that we are racialized into, our gender identity, the languages we speak, and our socioeconomic status can all impact vulnerability to the health hazards of climate change. And one of the most widely recognized examples of this is redlining. I think most of us are familiar with this, but just briefly, redlining is the practice of denying or limiting financial services to certain neighborhoods or communities based on their racial or ethnic makeup. And this discriminatory practice has historically led to economic disinvestment and persistent inequalities throughout neighborhoods. So shown here on the left are the red line neighborhoods of San Francisco that were created in the 1930s. Now, when we fast forward to today, we see that those same neighborhoods are disproportionately exposed to environmental hazards, including nitrogen dioxide and PM 2.5, or poor air quality. And it's not just poor air quality, but it's also things such as heat. We know that these same neighborhoods are disproportionately exposed to higher temperatures. And we can see that here on the right, which shows consistently higher temperatures in formerly redlined areas relative to non-redlined neighborhoods by as much as 45 degrees Fahrenheit. And these trends can be attributed to impervious surfaces, meaning more asphalt and concrete, leading to urban heat islands, but also simply due to less investment in green spaces, parks, and we can even see here fewer trees planted. And this is a local KQAD report that shows temperatures in an individual's SRO, and their apartment reached temperatures as high as 80 degrees when outdoor temperatures were only 70 degrees. So if we're thinking about patients undergoing chemotherapy and radiation who may be living in an SRO, we can certainly understand how they may be more vulnerable to climate change hazards. Which leads to the question, are our cancer centers ready to respond to a changing climate? Unfortunately, when our team investigated the national cancer centers across the United States, we found that they are not prepared to deliver care in a changing environment, with only 2 of the existing centers having environmental sustainability plans in place. Yet I will highlight here that the silver lining is that opportunity exists, given a large percentage of these cancer centers were affiliated with hospitals and universities that do have formal plans in place. And this was similar across California and radiation oncology facilities, with results from our survey showing that about half had known wildfire emergency plans in place. And only about a quarter of physicians reported that they were counseling their patients on emergency preparedness planning and what to do in the event of a wildfire. Again, highlighting significant opportunity for establishing adaptation and resiliency within our clinics. And so then this leads me to the next question, which was, what is healthcare's impact on climate change, or what is cancer care's impact on climate change? And although the healthcare sector remains on the front lines of the climate crisis, it paradoxically contributes to global warming. So today, healthcare is known to account for about 4.4% of global emissions. But if you just look at the US healthcare system, it accounts for 10% of all US all US emissions. And so if we, again, just look at the US healthcare sector, if it were a nation, it would actually rank 13th in the world for greenhouse gas emissions, ahead of the UK. So where are most of these emissions coming from? Well, most of healthcare emissions come from a variety of sources within the sector. Hospitals are certainly particularly energy intensive and contribute substantially. There are direct emissions, or what we call Scope 1 emissions, from healthcare facilities themselves. This can include on-site boilers and even certain medical gases and anesthetics that are direct greenhouse gases. For example, some hospitals' anesthetic drug use can contribute up to 40% of a hospital's direct admissions, with potent anesthetic gases such as desflurane, which have a lifespan much longer than that of CO2. However, the majority of the emissions are coming from Scope 3 emissions, and these are indirect emissions. So essentially, this is the burning of fossil fuels for activities ranging from powering our healthcare facilities to transporting supplies, even manufacturing pharmaceuticals. And we also know that hospitals contribute quite a bit of physical waste. So this has been quantified to be about 29 pounds of waste per hospital bed per day. And this represents not only an opportunity within healthcare for environmental stewardship, but also an opportunity to engage leadership and show that we can decrease spending, as many climate actions actually do. And so how do we actually calculate environmental impact of a healthcare sector, or specifically if we're thinking about a field of medicine or a practice, how is that done? And so I just want to shed a little bit of light on that. This can be done using a tool called life cycle assessments. A life cycle assessment is a tool used to quantify the environmental emissions or impacts of a product or a process throughout its life cycle. And so, for example, if we're thinking about just radiation oncology, this therapy may appear just to be a moment in time, but in reality, there are many things that go into the patient pathway, including the supplies needed, energy, capital equipment, transportation for the patients, for the staff, and then certainly the hospital infrastructure. So in reality, it's a complex process that needs all of these components to filter into it in order to have a successful treatment. And each of these components in the pathway, whether it's a supply item or capital equipment, all have an upstream workflow where they go from raw materials to extraction and production until they are ultimately transported to the clinical space. And then each item also has a downstream component or an end of life cycle process. And this could be recycling, reuse, or landfill. But essentially, all of these steps have a footprint, and there are emissions associated with each of these. And importantly, LCAs can provide a holistic understanding of these impacts. So not only greenhouse gases, which many of us are familiar with, but they can also report on other ecologic impacts, such as land use, ozone depletion, acidification, and even water depletion. And then you can take these midpoint or environmental impacts and translate them to endpoint impacts. Essentially, what does this mean in terms of human health? So a common way that you can do this is in DALYs, or something that we in the healthcare field are more familiar with. So within healthcare, LCAs have been used for a variety of reasons, including quantifying baseline emissions and identifying hotspots. So for example, this study on the left looked at different types of hysterectomies, whether it's laparoscopic or open, finding that single-use supplies contributed significantly. LCAs have also been used to quantify waste in a department. So for example, this study looked at waste in the ED. They can also be used to compare different products, oftentimes single-use or reusable, with common studies performed being reusable laryngoscopes, gowns, or speculums. And then they can also compare alternative clinical practices or patient pathways. And so I'm going to walk through an example of an LCA that we performed in radiation oncology to get back to one of my original questions, which is, what is the environmental impact of the care that we're delivering, but also what is the human health impact? And so actually going back here, what we did is we looked at a complete treatment course all the way from the patient's initial consultation through their last treatment or radiation treatment. And we looked at everything that goes into this, including the raw materials, the production, manufacturing, transportation for staff and patients, building energy use, and all the supplies and materials. And then we were able to quantify what is that environmental impact and what is the human health impact of the care that we're delivering. And we collected data from 4 institutions to make our results more broadly applicable. And then we looked at the 10 most commonly treated sites of disease that we deliver here at UCSF and actually nationally, again, with the goal of understanding what are our baseline emissions, what are our hotspots, and where are there opportunities for mitigation. And so I'm going to move through this quickly, but essentially we spent 3 months collecting data in our clinics, and we documented all the supplies used, including material type, weight, lifetimes, and this was done via direct observation and weighing. But we also did this through secondary data collection via discussions with procurement officers and review of product data sheets. And then we also spent time with buildings and facility management teams, understanding our building energy use and the energy use of our capital equipment. And then we even looked at UCSF zero carbon energy, which utilizes renewables. And then we also looked at staff transit via surveys to our department staff. And then we compared this with the UCSF commuter surveys. And then for patient transit, we looked at our department's treatment records to understand how far patients are traveling based on the different disease sites. And then we spent several months training our collaborators at other sites on how to replicate this data collection and even standardize some of our data collection forms. And then at the end of all this, what you do after collecting all this data is you calculate the impact of all these components by breaking them down into their smallest unit. For example, this could be a single medical glove. And then with the use of databases and resources like CIMA-Pro, you end up translating all of these things into the environmental impact categories to quantify your impact. And so we had a lot of interesting results from our study, but today I just want to emphasize that the goal of this is to quantify, again, baseline emissions, and then be able to target actionable items for mitigation. So I'm just going to run through a few of our interesting findings. The first was that building energy use, which is in blue, and transit, which is in yellow, accounted for the largest impact across all the environmental impact categories, with actually supplies, it's very hard to see here, being very minimal for radiation oncology. And the second was that we were able to understand what the average emissions per treatment was and begin to translate this into terms that our field could understand. And so we found that each treatment from initial consultation all the way through the end of treatment was about 4 tons of CO2 equivalent. So this would be equivalent to driving 10,000 miles for the perimeter of the United States, or taking 4 round-trip flights from San Francisco to Virginia. And then when we looked at building energy, we could see that a significant proportion was coming from HVAC systems, and especially from natural gas, which accounted for about 71% of the energy use emissions. And so this is a great opportunity for physicians to be advocates within their health systems to transition away from natural gas. But I will highlight here at UCSF, we're actually already in the process of doing so, with a significant decrease since 2015 of our natural gas. But certainly, highlights opportunities for action at other universities or health systems. And then also, when we started our life cycle assessment, all eyes were on our Linacs, our big treatment machines. But we found, interestingly, that our machines only accounted for about 4% of the total impact. But despite this, it highlighted an opportunity to partner with industry, who's been really excited to see physician advocates within this space. And then when it comes to transit was responsible for about 50% of total impacts in 6 out of 10 impact categories, accounting for about 14% in greenhouse gas emissions. But again, when you look holistically, it accounted for about 99.9% of carcinogenic potential. And so the reason why I highlight this is because of an intervention we're doing at UCSF, which I'll talk about here shortly. But we all know that addressing patient transit is very nuanced, and it will look different in each clinical setting and each department. And then interestingly, supplies within our specialty accounted for very minimal impact. And this is different than other LCAs, especially those that have been done in surgery. Again, emphasizing the need to perform such analyses in different settings and different specialties. And then for our field, we were able to discuss and simulate alternatives, such as what would happen if we implemented telehealth for the consultation component of our treatments, or what if we use hypofractionation using shorter treatments, or even advocating for zero carbon electricity, and we're able to quantify this for the different institutions. And so one area that I want to focus on, and what we decided to focus on here at UCSF, was addressing the patient transit. And so what do you do if patients require daily transportation for treatment, and low footprint modes of transit, such as walking or public transit, are very nuanced by social determinants of health, as previously discussed? Well, we realized that since many of our patients come to clinic via Uber using Uber Health application, that we transitioned and ran a pilot to see if patient transit emissions could be reduced by booking patients with Uber Green instead of conventional Ubers. And we found that not only were emissions reduced by 79%, but that there was no difference in price and there was no difference in wait times. And if projected out, that we could save 4.8 metric tons of CO2 emissions annually. And we are now continuing a longitudinal project with Uber this academic year, showing to date that these trends continue, both with ease of booking, few cancellations, but many emissions saved, and hopefully creating the opportunity and a pathway for Uber Green to be more broadly used at UCSF Health, but also at other health institutions in cities where Uber Green already exists. And then recognizing that LCAs are certainly very time intensive, and knowing that waste is especially high in surgical specialties, we felt that there remained an opportunity to reduce our impact in our brachytherapy procedural suites, a treatment that's very different than external beams, but rather is a surgical procedure we perform. Specifically in our department, we learned much more about waste when we were performing our LCAs, and we found that red bag waste in particular is not only financially costly due to the process it requires for sterilization, but also there is significant environmental impact due to the incineration process and even the transportation required to get this waste to the appropriate facilities to be processed. So in our department, we ran a procedural waste audit in which student auditors weighed and documented the procedural setup, and then came in after the procedure and weighed the red bag and the non-red bag waste, or the trash, and then also documented any unused supplies. And this is an area of decarbonization that I included today and want to emphasize because of the ability for other residents to run similar audits in their department. For example, this audit that we did last year was part of our GME QI requirements. And interestingly, what we found was that there was simply a lack of education around appropriate red bag waste disposal. Far too much was going into red bag that could actually simply go into landfill. And that was because the trash bin, or the kick bucket that sits underneath the physician's foot, was automatically put in as a red bag instead of landfill. And so at the end of the procedure, it prompted more items to go into red bag waste when cleaning up. And so we realized that by simply exchanging this kick bucket to be landfill or regular trash instead of red bag, we were able to essentially eliminate all of our red bag waste with a very easy implementation. And then recognizing that this only added 6 minutes to our workflow, we wanted to lower the threshold for other residents and other clinics to participate. And we created a tool for others to implement similar audits, which is now being used in residency programs as a QI initiative to reduce medical waste actually across the nation. And then lastly, we were able to partner with an AI company called Zabel to reduce the audit down to only 60 seconds, as the app can actually take photos and it will spit out the weight of the bag and note the items that were disposed of in there. And so these are just two examples of what can be done very practically in clinics for mitigation. But what about the work going beyond mitigation? Going back to the beginning of my presentation, thinking about how can we protect our vulnerable patients beyond just having less waste? So one thing that I would like everyone to take away from today is recognizing that climate action and climate solutions typically come in three flavors or three buckets of action. So moving beyond mitigation or primary prevention, we must also focus on building adaptation and resiliency, essentially having secondary prevention. And this includes adaptation, taking action to manage the risks of climate change impacts, but also resiliency, anticipating, preparing, responding, and recovering to climate impacts. And so today there are numerous tools to further assess community vulnerability to climate change. And I'll highlight this tool, the US Climate Vulnerability Index. This tool allows you to see which communities face the greatest challenges from the impacts of a changing climate. And then it also allows you to see what's driving these challenges. So policymakers, communities, healthcare systems themselves can actually take action to build climate resilience where it's needed most. But being on the front lines, I think we as physicians and researchers can also better understand the specific patient populations we serve, including our own clinic patients, and understand adaptation resiliency needed there. So a study that we're doing here at UCSF is looking at mistreatment visits during times of wildfires. And this was inspired by our national study that showed patients had longer treatment times. Essentially, they were missing visits. So when we looked at UCSF data, this showed to be true with an increase of missed visits during wildfires by about 2%. And so now we're collecting data from UCSF and 4 clinics across Northern California, also exposed to wildfires, so we can understand why patients are missing visits and how it impacts their outcomes, so we can adapt our future resiliency plans. And then there are numerous tools to integrate resiliency planning into our clinics today. And I want to highlight the AmeriCare's climate resiliency tools. And as you can see here on the bottom, they have education materials and action plans for patients, for providers, and administrative staff. And all these tools can be used to collaboratively build plans on an individual patient level or specific to the clinic. And then additionally, there are federal tools from HHS that can be used more broadly by health systems to, again, assess vulnerability, not on an individual patient level, but here you can actually focus on vulnerability from a facilities level and then develop out climate resilient healthcare facilities. And then the last question that I had, going back to the beginning, was how can we organize together to inspire change? Specifically for residents, how can you work within your spheres of influence to inspire the change that we want to see? And this is where I will highlight the power of collaborative action. So what started out as 2 interns seeing the impacts of climate change on their patients developed into a resident-led group at Stanford called Greening the Clinics, and a lab here at UCSF called Green Health that allows students and residents across the nation to work on the many projects that I discussed today. But also the 2 of us worked within our specialty and started a resident-led climate and health group that further gained attention from our larger professional society called ASTRO, who responded, created a task force, and even passed policy pertaining to climate change this past June. But there are also many other groups that have started to pop up, especially over the last 18 months, focused on whether it be oncology or other medical specialties, including radiology, pediatrics, and anesthesia, just to name a few. But now there's even a working group here at UCSF's Cancer Center focused on climate change. And I want to note, and leave everyone here with the fact that there is a true value when talking about climate change to talk about the health implications. We can all be ambassadors and storytellers of what we are seeing in our clinics on the front lines. We can make it human, and we can make the link for others between climate change and health, and we can tap into the shared value of human health. The stories we tell can help clarify the potential impact of climate action. They can create urgency and allow us all to imagine a healthier future. And so I must recognize that the work presented today is certainly a collaborative effort. And I want to thank the many people from UCSF who've participated in these projects, but also want to thank the students and the residents across the nation who've been working with Green Health Lab, our many collaborators and sponsors of these projects. I want to transition it over to Arianne Teherani to talk about the numerous opportunities to engage here at UCSF, the UC Center for Climate Health and Equity. And she can talk a little bit more about what's being done here at UCSF and how residents, physicians, faculty can all engage in these broader efforts.
Hi, everybody. My name is Arianne Teherani, and I am the founding co-director for the Center for Climate Health and Equity at the University of California, San Francisco. Building on the presentation that Katie just made, we want to take a moment to introduce you to the center, its purview, and its oversight. We launched the Center for Climate Health and Equity with a mission to harness the expertise and the leadership of the health sector to drive ambitious climate action that benefits health and health sector action that reduces the impact of climate change. Our vision has been to advance equitable and just climate solutions that promote human health and a healthy planet. So really taking both perspectives on the work that we do. We launched the center in July of 2021, and we're based here at UCSF. We received seed funding from the UC Office of the President, from UCSF leadership, and the rest of our funding comes from competitive grants. The center spans all 10 UC campuses and 5 health systems. And we have developed relationships and are partnering with over 100 faculty affiliates throughout the UC system. We believe that we have become a hub within the UC system for innovative scholarship and action on climate change and health, helping to bolster UC's role at the forefront of advancing healthy and equitable climate solutions for California and beyond. To date, our highest impact areas have been in education, research, and healthcare sustainability. We are leveraging the power of education to drive change with a goal to prepare a 21st century health workforce, as well as the public, to meet our greatest health challenge. We have trained over 100 faculty across the UC system on climate, health, and sustainability, and these efforts have reached over 7,000 students. We launched a course on climate and health justice. We've also developed patient care materials on the health impacts of wildfires, which are now housed in an online education hub and available in several languages. And we created the first fellowship we know of that's focused on sustainable development for health in Kenya. And we are training the next generation of Kenyan leaders to work at the intersection of development, climate change, and health. For research, we have been focusing on generating missing link evidence that's actionable and responsive to community needs. So, for example, we have studied an innovative climate adaptive water irrigation intervention in Kenya and demonstrated the impact on adolescent health, pediatric growth, and development, women's empowerment, so on and so forth. We've launched a UC-wide seed grant program to support climate, health, and equity projects. And in our first year, we received 46 LOIs from across the UC system. And we funded 4 grants on topics such as climate resilience education among indigenous communities in Guatemala and urban forest equity in Los Angeles. We're building a climate, health, and equity data dashboard for California that can be used by academics and policymakers to guide climate resilience planning and programs. And finally, we've been accelerating pathways towards climate resilient health sector. So, greening our health systems, developing climate sensitive patient care, and ensuring that public health infrastructure is prepared for acute and long-term climate threats. We have been overseeing some critical work across the UC system to reduce emissions from clinical practice. And we have launched a clinical sustainability fellowship. It's the first of its kind in the US to support and mentor UC faculty-led decarbonization projects. And with that, I'm going to close. If you do need to reach us, our website is at climatehealth, one word, at ucsf.edu. And we look forward to hearing from you. Thank you.
Question in the chat that says, as a radiologist, just curious how much medial imaging equipment contributed to your LCA analysis of oncology care?
Yeah. Thanks, Helen, for asking that question. So when we went into the LCA, as I mentioned, all eyes were on our treatment machines and the diagnostic imaging in a patient's workup that leads to that point. If we look at MRIs, we know that MRIs actually can contribute about 4% of total hospital energy and their impact. And so we were very curious, in our LCA, it was actually about 4% that our treatment machines contributed to that. The CTs that are required for treatment planning were very minimal, less than 1%. But, the big thing about LCAs is that you have to set your scope and your boundaries. So ultimately what we decided to do is start with the patient consultation. And so that then eliminates the workup, the diagnostic workup that the patient undergoes prior to seeing us. I think if we included MRIs and all the diagnostic imaging that's required, it would be much higher than that. But interestingly, it was actually very minimal. But again, that's swayed by the fact that our patients are coming for many weeks on end for treatment. And so when you think about a patient coming to and from, even if it's 30 miles, but they're coming for 30 treatments, that will really take a significant proportion of the total impact of an LCA. But we can't underscore that imaging does contribute to the energy use of a hospital, energy use of patient care. So there's certainly opportunities, again, to work with Philips and all these other industry partners that are working to drive down the energy use for diagnostic imaging. And I know actually here at UCSF, you may already be a part of this too, Helen, but we have been metering all of our different imaging in collaboration with industry and looking at opportunities for driving down the emissions. So a big thing that's been identified is that idle time, or time, that the treatment is not, that the machine's not being used, actually contributes quite a bit. So that's been a really exciting finding, from the surveys that we've been doing here at UCSF, or I guess the metering. So lots of opportunities, again, to drive that down.
Are there any other questions before we end? Thank you, everybody, for being here. If you could take a moment to fill out the Grand Round survey that is being placed into the chat, that would be wonderful. Thank you for spending a little bit of time with us. And thank you so much, Katie, for your wealth of information.
Great, thank you. And thank you for allowing us to expand on these topics at GME Ground Rounds. Much appreciated.